Welcome back. We have been submitted a case to evaluate implant for edentulous sites 29 and 30. So let's take a peek. The first thing I'm noticing in this particular case is that we used a bite plate, which certainly works. But my question would be in this case is, did we have to use a bite plate? And the first thing that makes me question that is the fact that we were able to get CEREC data in here. Now, of course, there's nothing wrong in using a bite plate, but what I do want us to be able to do is recognize when we have natural teeth, and in this case, tooth number 21 all the way through 28 are natural teeth that are great for CEREC integration. So based on this information, we can use an OptiGuide or a DigiGuide in this particular case, and we do not have to necessarily do the CCAT Classic protocol. So I like to avoid the classic protocol whenever possible, especially on what I consider relatively straightforward cases, which this one would be. So let's go ahead and take a look. The next thing that I will evaluate in this particular case is the quality of the design. As many of you know, I'm a stickler on the design being correct. So in this particular case, what I notice here is that our tooth designs aren't as accurate as we'd like them to be. One, we have a little bit of a gap here, we have a little bit of a gap here. I'm just a little bit of a stickler about getting these in the right spot. The other thing that I do notice is if I were to draw a line through here, we can see that our cusp tip on the premolar is drawn pretty well, but the one on the molar is not. The lingual does seem to be drawn pretty well there. So on the buccal, we can see that this tooth is definitely out or a little bit thicker than we would like it to be. That can make us put the implant a little bit too buccal. And if we take this down the line view of it, we can also see right here how that isn't as good as we would like it to be. So again, just little things that make a little bit of a difference along the way. And then we'll go from here, and now we'll take a look at our implant plans. One last thing on the implant plan itself. I did notice that these were designed as 29 and 30 independently, single crowns. When we have teeth side by side, my preference is to design it as a bridge. So I would call it bridge crown 29, bridge crown 30. What that would allow us to do is have these come in as one single restoration, so we'd only have to bring in one SSI file. So let's go ahead and take a closer peek at these plans. So let's go ahead and focus on tooth number 29 first, and let's go through buccal lingually. I would say that we're pretty well centered. Certainly we have some questions about how thin this may be right here. Mesiodistally, we've got plenty of space. Bone level, this is where these become questionable. That's the lingual bone level that would require grafting. Also in this particular case, we can see our emergence would be compromised. So this may actually be the best, most ideal position to place the implant would be to just go straight down. Anatomical structures or vital structures. Here we can see the mental foramen. We are away from that. I also take a quick look for the anterior loop to make sure it doesn't suddenly move where I want it to be. Another potential vital structure here is the dip in the lingual concavity right here. So I do want to be very mindful of that. In this particular case, we may consider going to a 9mm implant, but on such a narrow diameter, I would be a little bit more comfortable going 10.5, but I would definitely be cognizant of this drilling, the drills I'm using, the extra length of the drills, any undersizing that may need to be done to avoid any potential risk of breaking through that lingual plate. So then we'll take a look at our occlusal table. And here what I see is that our occlusal table leads us to see that the implant is definitely on the distal side of that premolar. So what I would do in this particular case is just go ahead and move the implant so that it is a little bit more centered in the tooth. And that looks a lot better right there. And then kind of move along from there. And then we'll look at our occlusal plane. And here in this particular view, our occlusal plane looks quite nice. So I would say that this implant is planned pretty darn well. The only major change that we made in this particular plan is moving the implant to the mesial to get our implant restoration better centered, the implant centered through the restoration. Now we'll go ahead and go to tooth number 30. So when I do plan two teeth side by side, my preference is once I get 29 ideal, I will actually just simply make 30 parallel to 29 to see if I can take care of that. So I'm going to cancel that here and walk through this plan buccolingually. Buccolingually again looks good. Ideally we'd put the implant somewhere here, maybe do a little bit of grafting, but certainly I can live with a little bit of countersinking, especially if we're going to end up losing 31 here. I can certainly live with a little countersinking to give us space and just take care of that without having to graft. Mesiodistally, again, more than enough space there. Vital structures, we've got plenty of distance between the nerve. I would possibly consider doing a wider diameter implant here, but again, that comes out of the ridge. So a 4.6 would probably be okay in this particular situation. With a small, what I would consider a smaller diameter for a molar, typically I like to do 5 or greater. I would definitely look at making sure that I don't have such a wide restoration on top of that, and as we discussed earlier, this restoration is too wide. If we go to our occlusal table, we can see that we're pretty well centered. Again, I would come back to point out that we have a gap here and a gap here. I really doubt our molar is going to be this wide. So I would, in this particular case, have a tendency to move this to the mesial as well. And that would probably be a little bit more accurate in terms of final restoration placement. And then our occlusal plane. And what I'm seeing on our occlusal plane on this one is that we have a little bit of an upward tilt to this. Like so. So I would definitely go ahead and tilt this implant like so to get that a little bit better there. And there you can see our crown looks a little bit better. So if you have, so I'm going to uncorrect that. If you had noticed, when we make this parallel to 29, it also goes ahead and corrects our occlusal plane issue because 29 was parallel to our occlusal plane. So I would definitely go ahead and bring this over to the mesial a little bit and leave it about like so. The other thing that we'll notice is we'll take a look at the down the line view here, and we can see that our implants are pretty well placed. In retrospect, looking at 29, I may want to move that a little bit to the buccal. That would probably be a little bit better placement there, something like that. Again, just a minor amount like so will tremendously help with that. And then I think 30 looks quite nice. So we weren't too off. Just need to take a look at a few things. Let's go ahead and look at our sleeves as well. Change our sleeve and go to the BioHorizon sleeve system, which I do not have in the software. So we can evaluate to see if the sleeve would fit. My guess would be okay. Just would check right here on the distal to make sure that sleeve fits. So thank you very much, and look forward to seeing some additional cases.